All right, everybody ready?
Yes.
Yes, with your books, with your notebooks and all that. Okay, cool.
Yes.
Maladies. So before we dive into all that we're going to cover today, I would like to show you a picture. A picture. Okay, I hope everybody can see this. This is the layer of the heart. I'm sure most of us are familiar with it, but just want to make sure everybody's on the same page. All right, as you can see here, these are the main layers of the heart. First, you can see the innermost layer, that is the endocardium. And whenever we talk about the endocardium, we will always refer it to the innermost layer of the heart, and the most frequently affected one will be the valves of the heart. Second layer will be the myocardium, as you can see here. The third layer. This third layer, some people call it epicardium. Some people consider it as part of the pericardium. And as if I like this picture because it covers both, and it depends on what you want to refer it as. That's entirely up to you. So just like any other, not really any other, just like some layers, some organs that are in our body, like the abdominal cavity, like the lungs, like the brain, they all have something that covers it, right? And so does the heart. And what covers the heart is the pericardium. And just like your lungs and just like your abdomen, you have your parietal layer, that is the outer layer, and also a visceral layer, that is your internal layer. And the visceral pericardium is what they call epicardium. Okay, and what's outside of the outermost layer is your parietal pericardium, or just people would just refer it as the pericardium instead of the parietal pericardium, and they call the visceral pericardium as the epicardium, as what people are most familiar with. And just like it is in your abdomen with your visceral peritoneum, parietal peritoneum, just like it is in your lungs, your parietal and visceral pleura, you also have a space. The lungs, we call it pleural cavity, right? And in the peritoneum, we call it peritoneal space. Or well, I don't know if it's actually called peritoneal space, but anyway, it's not really common to call it peritoneal space. Anyway, just uh, just like just like it is there, you also can see a space in between your visceral and parietal pericardium, and that is what people call pericardial sac or pericardial cavity, most commonly called pericardial sac. Now, why is it important? We will learn today that some fluid can enter the sac, and we'll call it pericardial effusion, and when it's massive, we call it cardiac tamponade. And cardiac tamponade is an emergency situation, and it's not something that we want to delay. Anyway, knowing all of this, we are going to go layer by layer, layer by layer. We will start with the endocardium. Okay, if that's okay. Or would you prefer to start from the outer layer, pericardium, the pericardium? Anyway, I don't see the difference anyway. We can start with the innermost layer, and that is your endocardium. And bear in mind what we're going to cover today, as much as it refers to the inflammation of these walls. When it comes to etiology, what we're going to cover most today will be infectious. And for endocarditis, we are only going to cover infectious endocarditis. And bear in mind that just because the endocardium or pericardium or myocardium is inflamed does not mean that that the etiology is um, infectious in nature. So with that in mind, let's start with infective endocarditis, okay? Whenever we talk about infective endocarditis, we need to first consider the risk group, the people who are most commonly affected by it. And knowing the risk group, we will also eventually know which strain of bacteria that can cause that affects the specific group of people. And knowing specific strain, subsequently we will know what to give when it comes to treatment. And we all know that when it comes to bacteria, to go against bacteria is your antibiotics, yeah. And we have a gazillion and set of antibiotics, and knowing which strain is very important when it comes to empirical therapy, and it will be specific to the specific strain of bacteria, instead of blindly throwing in an antibiotic and hopefully will kill those bacteria. We'll talk about blind, so-called this blind therapy and so-called empirical therapy, and we've covered a little bit on that, right? When we covered antibiotics, and we've covered with we talked about the importance of knowing the specific strain of bacteria, and and instead of giving just broad spectrum antibiotics, which we as people in the medical field will often resort towards, because that's just the most convenient thing, and that in the long run is not sustainable. And the most sustainable way to treat specific strain of infection or any form of infection is some form of empirical therapy, and that is to give specific form of antibiotics. Anyway, let's start with infective endocarditis, yeah. So infective endocarditis, we have, like I said earlier on, we have to know the specific group of people that um, are affected by endocarditis, by this infectious endocarditis. First, before we go into specific set of group, we need to know some terms, right? Whenever you read a couple of books, or read guidelines, or watch stuff online, the couple of terms that I would like to clarify, and I don't think these materials clarified unless you actually put in the effort to clarify it yourself. But let's just clarify some terms that you might come across if you've actually read some of the things that are written in this guideline. First and foremost is the term native valve. Whenever we talk about native, right, especially as people, when we refer to the native people, we refer to the set of people who actually belong to that land, right? They are not people who have colonized the land, or people from imported from outside because of some labor immigration or migration and stuff like that. But when we talk about native, when we use the term native, we often refer it to people who are originally there. So the same goes to the term native valves. It means that the valves, whenever we use the term native valves, we refer it to the valves that are actually originally there. Endocarditis, remember when we talk about the endocardium, it is often related to the valve. So we are going to talk about the valves now. Why is this important? It's because the risk of having endocarditis or infectious endocarditis increases when some set of people, maybe with valvular diseases, valvular heart diseases, the most common way to treat valvular heart diseases is to replace the valve with a prosthetic valve, be it from a different organ, a different animal, for example, bovine prosthetic valves, or just a human prosthetic valve. Regardless, they are not native, so as to speak, to the body. The risk of getting endocarditis amongst patients with prosthetic valves will increase. It increases significantly, and understanding this, it means that even if the patient does not have any history of endocarditis, there are some procedures that will also increase the risk of getting of having of being affected by infective endocarditis. And because of this, we need to prescribe prophylaxis for it as well. One of the most common procedure that people that is commonly that was found to be one of the common causes of infective endocarditis amongst patients with prosthetic valves are dental procedures. There are so many different, we'll talk about prophylaxis a little bit later, but dental procedures, people who have gone through any dental procedures, putting putting braces, teeth removal, scaling, and so many more, it also increases the risk of getting endocarditis, because these specific strains of bacteria, uh, we'll talk about that later, can travel into your bloodstream. And especially when it comes to dental procedures, when you remove something, it's a very sensitive area, right? And it's very prone to bleeding, and bacteria can just easily enter into the bloodstream. And the most common, or in fact the only way uh, the endocardium gets affected is actually through hematogenous way, and that is through the blood. Knowing this, understanding this, it means that endocarditis itself, infectious endocarditis, is secondary to septicemia. Okay, so it means that in the blood there is some form of bacteria circulating, and it eventually lands on your valves, because your heart is a pumping machine, right? So the blood easily gets there, right? So besides dental procedures, it is also common for drug abuse patients with IV drug abuse, especially abusers, to have infective endocarditis as well, because obviously you inject something outside, non-sterile, goes into your bloodstream, goes to your heart. Well, you know the story, right? Another risk factor for infectious endocarditis are people with history of endocarditis. So knowing this, it's important when it comes to prophylaxis as well, when it comes to treatment. Now, I talked earlier on about native valves, right? So we've talked about prosthetic valves. Now let's talk about so-called native valves. So how can it affect the endocardium if there's nothing external? So this means that the problem is from the beginning. So what that means is that there is a congenital problem, and very common. We'll talk maybe in the future to talk about congenital heart diseases, which I ask everybody if we would like to cover. It's not very common to deal. It's not very common to see it in hospitals, but it's still a subject that is worth talking about. That we have a lot of congenital heart diseases, and very commonly we talk about it in pediatric circles instead of therapy, because it is commonly detected amongst kids instead of adults. But It is also divided into pediatric congenital heart diseases and also adult congenital heart diseases. But regardless, the congenital heart disease defects or diseases that is a risk factor for infective endocarditis are your patent ductus arteriosus, and yeah, that's all. That's all. And there are other congenital heart diseases, not very much. And there are some exceptions like your atrial septal defects, your ventricular septal defects, which are your congenital heart diseases as well. Then the risk for them to not get endocarditis is not very high, and the most common amongst all congenital heart diseases, the highest risk are people with patent ductus arteriosus, or PDA in short. Okay, next, another set of people who are prone to getting infective endocarditis are people who have history of rheumatic heart diseases or rheumatic valvular heart diseases. We all understand. We'll talk, if we have time, we'll talk about rheumatic fever. If we don't have time, maybe we'll talk about rheumatic fever next week and all that. It's a very big topic as well to cover, and I don't want to rush anything. So, but anyway, if you feel like I'm talking too fast today, I feel like I'm talking too fast today. I don't know why. Um, Maybe because we have new people. I don't know. I feel nervous. But anyway, if I'm talking a little bit too fast, please just you can unmute yourself and tell me, hey, talk slower, okay? Um, and if you need me to repeat a couple of things, do just let me know. I don't mind repeating it as long as everybody understands. Okay. All right. As I talked earlier on rheumatic valvular patients with rheumatic valvular diseases, especially diseases that increases the flow of the blood as blood flows through the valve. And what I mean are stenotic valvular heart diseases. Any valve. I'm not specifying it to any set of valves. Just any stenotic heart valvular diseases. It increases your risk for get endocarditis because your blood is simply just flowing very quick, and because of that, if there is any septicemia in your blood, that increases your risk for that as well. All right, so let's see if I've covered everything that I want to cover when it comes to risk factor. Oop. Okay, now I think I've covered most of the risk groups, and I hope everybody understands how important it is to identify your risk groups. Okay, next thing that I want to move forward to, as I mentioned earlier on, knowing your risk group will also subsequently know the specific strain of bacteria that affect the specific groups of people. Now, let's start with native valves or your congenital heart diseases, patients with congenital heart diseases, or not just congenital heart diseases, just when the valves are intact, when your valves are native. The most common strain of bacteria is your Streptococcus viridans, viridans, Streptococcus viridans. Others are not very common. Your enterococci are not very common. Your Staph aureus, Staphylococcus aureus is not very common, but it can still happen as well. It can still infect as well. Your Staphylococcus epidermidis is also can also affect, but the most common one, about 50 to 60% of cases, are your strep viridans. Okay. Second, amongst narcotic addicts, drug users, is your Staph aureus. Staphylococcus aureus. Close to 95%, very common. Close to 95% of patients, of drug addicts with infectious endocarditis is because of Staph aureus. Patients with prosthetic valves. Most common is your Staphylococcus epidermidis, Epidermidis, epidermidis. Next will be your Staph aureus, then your strep viridans. Okay, clear, right? Next, another issue, another method that I would like to talk about, and this is very important. Remember when we covered antibiotics, our classes on antibiotics, we talked about MRSA, 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 right? Maybe you've heard of this before. Methicillin-resistant Staphylococcus aureus. It's a huge problem because the strains of bacteria that are growing that is growing in number, being resistant to penicillins especially, is just getting higher and higher, and the drugs that we are using right now is no longer effective. So it means that what we need to prescribe, we need to consider MRSA as well. We need to consider non-MRSA as well. So regardless whether it's MRSA or not, we have to consider resistance as well. Okay, just don't forget that. Another group of bacteria. It's not very important. I don't think it's being talked about a lot. It's called the HASEC group. HASEC, it's in the chat. HASEC group. It's like specific name. H is for Haemophilus. A is for, I don't remember what it is. C is for something. E is for something. K is for something. The reason why I think I don't think it's very important, or it's not being effectively studied or very common, is because the only when I first read about this group of bacteria, the only group that I've heard before is H, Haemophilus aeruginosa. The rest is they're just weird names. You can Google it up. You can find what the HASIC group is, and you can read more on it at your leisure time. But bear in mind, when it comes to treatment, we have to consider HASIC group as well. Okay. Let's see, what else should I cover? Okay, we've talked about specific groups of bacteria, done. Risk group, done. Okay, let's talk about classification. Classification is usually infectious endocarditis. It is usually divided into your acute infective endocarditis or subacute infective endocarditis. And here in KSMU, when we put the diagnosis of endocarditis, especially infective endocarditis, number one, we have to write acute or subacute, bacterial, or any other kind of etiology. Oh, by the way, other things can also cause endocarditis, not just bacteria, viruses as well. Fungi also as well can cause endocarditis. I'll show you later another picture of different kinds, different non-bacterial causes of endocarditis, and they still fall under infective endocarditis. So it's important when you write your diagnosis, it's important to write your bacterial, subacute, bacterial, infective endocarditis. Some of them would say primary because the when it comes to the actual problem in the heart. For example, your congenital heart diseases and stuff like that, those are considered primary or idiopathic if you don't know what it is. Some of them might consider putting secondary, but I've read the guideline from the European Cardiology Society of Cardiology. They did not cover anything on primary and secondary in um, putting primary or secondary, the term primary or secondary in your diagnosis. So I'm not really sure about that. Maybe it's just in case, and maybe it's just in Russia. So I'm not really sure. So I'm just throwing it out there that it exists somewhere. So, but generally, from the materials that I've been using to prepare for today's class, generally speaking, acute and subacute is something that people agree on. So what is considered acute and what is considered subacute? And from the name itself, it refers to duration, right? Whenever we talk about chronicity of a problem, it's always in reference to time. So acute, it simply means that it's very quick. Subacute, it means that it's not as quick, but it is, the onset is pretty slow, but it is progressing. Okay, but it's not like so slow to a point that it becomes chronic. I've not read anything on chronic infective endocarditis. Maybe it exists somewhere, I don't know, but I've not, I did, when I prepared for today's class, I did not read anything on chronic infective endocarditis, but if there is, okay, cool. So acute infective endocarditis, when a patient comes in, when we suspect endocarditis when number one, there is fever, and number two, murmur. Especially it's a new onset murmur, and we ask maybe the patient does not have any heart problem and stuff like that. But fever and murmur is are two let's say two landmarks that can direct you towards putting your diagnosis, your infective endocarditis diagnosis. So then the next thing that you have to do is to, if when you suspect infective endocarditis, of course you need to perform some tests and all that, but there are some things that can help you to decide whether it's acute or subacute. Number one is to understand the risk group, like what we talked about earlier on. Acute infective endocarditis most often happens in your narcotic addict, your drug abusers, your IV drug users. So because that is very quick, it goes directly into your heart. So that kind of gives you it helps you to think about to call it acute infective endocarditis. The rest, prosthetic valves, be prosthetic valves or native valves, they most often fall under subacute infective endocarditis. Okay, so that's why I said it's important to know who your patient is. Second is through your signs and symptoms. Your acute infective endocarditis is very serious. It's very, when the signs and symptoms are very fulminant, very quick, very serious, and there's hemodynamic instability. The patient looks very unstable. There's also risk for thrombosis. There's also risk for heart failure and stuff like that. It's very, very serious. And the progression is very quick as well. So that also gives you an indication that it's actually acute infective endocarditis. Whereas subacute infective endocarditis is pretty slow. Symptoms can be flu-like, can be weakness, can be just low-grade fever. Fever still is still present, but might not be as high. Weight loss, and very non-specific signs of inflammatory signs. and that can give you a picture, an indication that it's not very serious and it's subacute infective endocarditis. However, there are other signs that that you can see during physical examination, and I'll talk about it right now. Let me show you a picture, another picture. Oh, I did not. Not download the picture. Let me find it. Okay, found it. Okay, when it comes to infective endocarditis, like any other diseases, we have certain criteria that we have to cover for us to be sure that it's infective endocarditis. And as we fill all these criteria, um, it it confirms our diagnosis. So it's called Duke's criteria for infective endocarditis. It consists of two parts: your major criteria and your minor criteria. So your major criteria, as you can see, let me zoom in. Your major criteria, you see, it consists of two parts: your positive blood culture and endocardium, and your positive echocardium, your echo. So the thing about these two criteria is that you see the first criteria, positive blood culture. If the patient is having acute infective endocarditis, of course, we need to treat the patient very quickly. Also, even if it's subacute, we still need to treat the patient quite quickly. So the first, most often than not, the first criteria is very often omitted because we don't have time. Although it's still there, positive blood culture. Coming back, typical organism in two separate cultures, you can see positive blood culture, um, 12 hours apart and stuff like that. You can read it on what I'm showing to everybody. But it's difficult to get it, as I said earlier on. So the most helpful way to diagnose and to confirm your diagnosis is your echocardiogram, your ultrasound of the heart. And you can see vegetations, abscess, you see dehiscence of your prosthetic valve, itaglale. So you see all these things showing positive signs of some valvular defects, right? Any valvular defects or new valvular regurgitation you see and stuff like that. Whatever it is, you see that the valves are problematic and it gives positive echocardiogram. That's your point number one. Means that you have one major criteria. And to put your diagnosis, you need either two major criteria or one major and three minor. If you don't have your major, you see all five minor criteria. But most often than not, when we perform echocardiogram, we can see all these problems, and you can already cover one major, and you just need to cover three more minors, and that's it. So minor criteria. See here, there are a few points here. Minor criteria: predisposition, cardiac lesions, IV drug abuse. We've covered this. We've talked about this right before. The risk, the set of people are affected by it. So if it fits the risk group that we talked earlier on, see 1 point is already you can tick 1 point already. Second is fever above 38 degrees. So fever, as I mentioned earlier on, when a patient walks in with fever and murmur, you can first suspect infective endocarditis. So see if a patient has fever, tick, sure. Now, vascular and immunological signs. So this is what I want to talk a little extensive on. So you see, I'm going to close this picture and we'll come back to this. Okay, just bear in mind the third point is vascular. Just bear in mind that the third point is vascular and immunological. two groups, yeah? Two groups of signs, vascular / immunological. I'll talk about it soon. Hold on. Okay, now, vascular. What falls under vascular is petechia. 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 It happens because of vasculitis or any emboli. You know, when it comes to valve problems, you also increase risk for embolism as well. So you see, there are hemorrhagic spots. Yeah, you know, there are so many different hemorrhagic spots, different sizes, different diameter and stuff like that, different borders and stuff like that. Petechia. So first, vascular signs, petechia. They are red. They are non-blanching lesions. Now, what does that mean? Non-blanching. Non-blanching, it means that when you press that lesion and you let go, it does not disappear. That's what non-blanching means. But if you press and it disappears, it's called blanching. Okay, so you can see petechia not just on your skin, but also on your eyes as well, conjunctiva, on your mucosal membrane, your extremities, and any parts of the body you can see petechia because of vasculitis or emboli. Okay. Second is something called splinter hemorrhage. Splinter hemorrhage. You know, when you get splinter on your hands and or anyway, when we talk about wood splinters and stuff like that, they're like filaments, right? So the same thing as this splinter hemorrhage. It's when the hemorrhagic spots, they are very linear, they are red, they can be brown too, and they are very often seen on your nail beds. Your nail, what's inside, what's cushioning your nail. You can see splinter hemorrhages. Again, this also is caused by vasculitis or emboli. Next point is something called Osler's nodes. Now, Osler's node, this falls under immunological sign, not vascular. Why? It's because the body is trying to react towards the causative agent, and it causes the formation of so-called nodules on your fingertips or your toes, and they are very painful. So they are called Osler's nodules. Next is called Janeway lesions. Janeway lesions. Janeway lesions. They are a form of they fall under vascular signs. They are also hemorrhagic spots under hemorrhagic skin lesions, but they are not like petechia. They are slightly bigger and they are macular in size. They are not like petechia is a bit sorry, upside down. I said Janeway lesions is bigger, right? Actually, Janeway lesion is smaller, but petechia is bigger and covers a bigger surface area. Whereas Janeway lesions, they are macular. They are spots, small spots. They can be on your palms. They can be on your soles, and they are painless. Color is still the same. Red can be red, brown too, but they are macular hemorrhagic spots, and this is called Janeway lesions, and this is caused by emboli, not your vasculitis, your inflammation of your vessels. Last but not least is something called Roth spots, R-O-T-H apostrophe S, rough spots. This is on your eye. There are also hemorrhagic spots, also caused by vasculitis, but you can only see it on your ophthalmoscope. Can't just see it like that. You can probably if it's big enough. But then again, you can easily mistaken it with petechia. As I mentioned earlier on, your petechia can also be seen on your conjunctiva. So your rough spots is also on your eye. They are oval, they are pale, and they can be on your retina. They are oval, pale, around your retina, and it's surrounded by petechia as well. Okay, clear? So that is what it means in the criteria, in your Duke's criteria by vascular or immunological signs, your third point, right? Your first point was your risk factor, your group of people. Second point is fever. Third point is vascular or immunological signs. And let's see. Fourth point, positive blood culture that does not meet major criteria, or positive echocardiogram that does not meet major criteria. Very ambiguous and it's very confusing. Positive blood culture that does not meet major criteria. What does that mean? Positive echocardiogram that does not meet major criteria. It means that when you do your major criteria, you see it says your typical organism in two separate cultures or persistently positive culture, for example, 3 continuous culture, and they are 12 hours apart, or majorly if 4. It means that you need different cultures and you need to have them separately, and there has to be some form of gap between this culture and yeah. And remember, bear in mind, this is blood culture, okay? So it's not difficult to get, just draw blood out and just put it in a culture. And it's not that you go and dig deep into your heart and just grab some and take a biopsy of the heart and just make a culture out of it. No, it's not that. So if it does not fit these two sub points, then that's what it means here, positive blood culture that does not meet major criteria. Next is your positive echocardiogram that does not meet your major criteria. You see that it's not, I think these points are very specific. So your fourth and fifth point of minor criteria is a bit confusing and also not very much helpful. But they just put it there just so that your major criteria, they can rule out if there are any instances where your major criteria cannot be fulfilled, then see these 2 points, these two final points in your minor criteria will play into the picture. That is why you can put your diagnosis. Number 1, when there are 2 major criteria, 1 major with 3, you see 3 predisposition group, fever, and vascular immunological signs without the 4th and 5th point, because remember I said this now 4th and 5th point is very ambiguous and confusing. And or if there are any instances where your major criteria is a bit difficult to put your finger on or to be certain about, so that is why you can now consider your 4th and 5th point in your major criteria. And when you have all 5 minor criteria in your Duke's criteria, you can also already put your diagnosis for infective endocarditis. Okay, any questions so far?
Nope.
Нет. Хорошо. Let's see if I missed out on any points. Okay, no, I did not miss out any points. We can move on. All right, let's move on to how to treat infective endocarditis. Okay, how to treat infective endocarditis. Now, of course, knowing that it's infective in nature, right? So it means that you have to give antibiotics, right? And early on, we understand that the major groups of your causative agents are your streptococcus, staphylococcus, your HASEC group of um, bacteria, and also amongst these three, you have to also consider MRSA and non-MRSA as well, right? And as we also have discussed that we can only identify the causative agent after a positive blood culture, which takes time. But if we don't have time, it means unfortunately, we have to start with blind therapy. It means that our prescription of antibiotics will have to be broad. Unfortunately, we want it to be specific, but at this point in time, we can't. We don't have we're not privileged to do that. So, but then again, although getting positive blood culture would be the most definitive way to identify your bacterial strain, like we talked earlier on, when you identify your group of people who are affected by infective endocarditis, and understanding that um, from history, from all the research and all that, which bacteria is more commonly detected amongst this set of people, it means that there is still a chance that we can give proper empirical therapy instead of blind therapy, instead of bombing. Our clinical pharmacology teacher will call it carpet bombing instead of carpet bombing on bacteria. So and so with that in mind, there's still hope. There's still hope, right? So uh, if you like, if you would like to give empirical therapy, knowing your specific strain, for example, streptococcus, it means that you can already give your penicillins, right? Streptococcus, you can give your penicillins, oxycillin, benzopenicillins, and whichever penicillins you want to give, it can still work because you want to fight streptococcus. You can also couple it with gentamicin together with your penicillin. And of course, we've talked about when it comes to the usage of penicillin, there's still also risk for allergy, right? Some people are allergic to penicillins, and therefore we need to change. We can't use cephalosporins, remember, because of cross reaction, because cephalosporins and penicillins are both beta-lactam antibiotics, and they are alike. So we can't give our alternative antibiotics should not be cephalosporins. So you can substitute it with any macrolides, your erythromycin, azithromycin, clarithromycin, whichever it is that you want to throw in, you can throw in. Couple it together with gentamicin, you'll be fine. If you want to go against streptococcus, if your game is to fight against streptococcus. But if your game is against staphylococcus, you can also give your quinolones, or your penicillins too. You can actually give your penicillins. And the most common penicillin that people give for infective endocarditis, especially against staphylococcus, is flucloxacillin. FLU, flu, clox, CLOX, A, cillin. Flucloxacillin. But if you would like, if you unfortunately cannot give blind therapy, then which very most often happens, which most of the time it happens, you have to carpet bomb, you have to initiate blind therapy. And at this point, I've read the guideline that this is actually the first line of antibiotic given for infective endocarditis is vancomycin. Why is vancomycin preferable compared to other antibiotics? Is because it's broad enough, it covers your staph, it covers your strep, it covers your MRSA, it covers your HACCP groups of antibiotics of bacteria. Vancomycin plus gentamicin, you're good to go. If you don't know it's staph or strep and stuff like that, because or you're scared that there are some other forms of non-typical bacteria. So if you're scared of that, just give vancomycin and gentamicin, you're good to go. Okay. All right. Of course, there is risk for heart failure, like I said earlier on, especially for your acute infective endocarditis. There's also risk for congestive heart failure. So if congestive heart failure happens, it means that you have to treat congestive heart failure as congestive heart failure, like we covered last week, right? Your first line of drug and stuff like that. So it's interrelated. So that is why we cover all these things, so that if this happens, you treat the first problem, and if it's complicated by another problem, you can just refer to the topics that we've covered before. All right. Let's talk about prophylaxis. Let's talk about prophylaxis. Like I said earlier on, if patient comes in with history of infective endocarditis, definitely you need to perform prophylaxis. Again, we give the same set of drug. Actually, we give the same set of drug, vancomycin or gentamicin, prophylactically, 30 to 1 hour. You can give about an hour before the procedure that you want to make, just for prophylaxis purposes. And that is most often your dental procedures. You don't have to know when to not give prophylaxis therapy, but you need to know when to give prophylaxis therapy, right? One second. Right. So from the name prophylaxis, you know that we want to prevent the development of your infective endocarditis, right? So earlier on, I talked about dental procedures. Second are your patients with prosthetic heart diseases. So any procedures, prosthetic heart, although they don't have signs, or they don't even have history of infective endocarditis, you need to prevent endocarditis to occur as well. Patients with congenital heart diseases, all congenital heart diseases, except your arterial septal defect or your ventricular septal defect, as I mentioned earlier on, right? That it's very commonly seen in your patient with patent ductus arteriosus, but there's so many other congenital heart diseases. But generally, the rule is for all congenital heart diseases except your septal defects. Next is patients with mitral valve prolapse. Your patients with mitral valve prolapse. Besides dental procedures, any procedures in your oral cavity or your throat, also we need to bear in mind as well. If you want to remove your tonsils, you want to remove your adenoids, your tonsillectomy, adenectomy. You also need to perform such prophylaxis as well. You can give your vancomycin and your gentamicin, as we talked earlier on. But the thing is that vancomycin is not a very cheap antibiotic because it is used to fight against MRSA. When we talk about antibiotics, remember the first line to talk to treat MRSA when you suspect MRSA is actually your vancomycin. So some people might not prefer it because it's expensive. So you probably can give your penicillins, right? Of course, it's not optimum. You can give any penicillins. Optimally your amoxicillin, your amoxiclav, or your augmentin, if you would like to use brand names. But amoxicillin, you can give. You can also, if patient is allergic to penicillins, you can give macrolides. Or if you don't want to give penicillins and the patient does not have any allergy towards penicillin, you can give cephalosporins as well. Your third generation, your ceftriaxone, cefapime, it's fine too. But again, it's given 30 minutes to 1 hour before the procedure. Okay. I think we've talked very extensively on infective endocarditis. We've not touched on myocarditis or pericarditis. Before we move on, do you have any questions? No?
You said something about you give this prophylaxis to every other congenital heart disease apart from septal defect. Is there a reason?
Actually, remember I said earlier on that your defects, the velocity or the speed of the blood that flows in your heart also increases the risk of getting infective endocarditis in stenotic valves, right? So in septal defect or ventricular defects, the defects are very big. So the flow of blood is not as quick. So there is not much risk for infective endocarditis there. But in patent ductus arteriosus, when there is sort of like a window, right? If you know what PDA is, a window. And because of that, the velocity of the blood is very quick. That is why you see very most often in PDA instead of your septal defects.
Thank you.
Okay, all right.
Yeah.
No more questions? Oh, there's something, okay. All right, let's move on. I think we should move on to pericarditis instead of myocarditis, because I think myocarditis is we can cover it very quick. Not much there, but pericardial diseases is very, very big. Because we need to talk about acute pericarditis, we need to talk about pericardial effusion, we need to talk about tamponade, and we also need to talk about constrictive pericarditis as well. So a lot of things that we need to cover. So if you're ready, let's start with acute pericarditis. Let's start with causes of acute pericarditis, okay? And remember we talked earlier on infectious endocarditis, right? But when it comes to pericarditis, remember, I want you to notice, notice, is that the word? Okay, notice notice that there's no infectious the diagnosis is not infectious pericarditis or non-infectious pericarditis. It's acute pericarditis. So number one, it means that it's very quick. Yeah, that is why understanding this, it means that the problem, the causes can be infectious and can be non-infectious. it's very broad, and they are all they all equally, they have equal bearing. They happen almost the same frequently. So that's why they call it, just simply call it acute pericarditis. And unfortunately, the most common causes of acute pericarditis is not known. It's idiopathic. And when it's infectious, when it's infectious, it is usually caused by viruses instead of bacteria. Sometimes fungus, but very common virus. Your Coxsackie virus, your E. coli virus, and so many different viruses that can cause acute pericarditis. I'm not saying I'm not saying that the most often cause of acute pericarditis is virus. I'm saying that when it comes to infectious causes of pericarditis, it is usually viral. Okay. Inflammation causes inflammatory causes of acute pericarditis. It can also be autoimmune. It can also be autoimmune in SLE. If if you are in fifth year, above fifth year, when we cover SLE in fifth year therapy, there's this thing called as lupus pericarditis, and this is it, autoimmune. Also in rheumatoid arthritis, also as well, all these rheumatic diseases, it causes, it can cause pericarditis. Another very common cause of pericarditis is uremia. There's increase of urea in the blood. Metabolic causes of uremia can cause acute pericarditis. And next, another cause of acute pericarditis is post-MI, recent MI attack. I'm sure most, but one of we have students from above fourth year, and we also have third year students, yeah. But I'm sure most of us have at least touched or read on post MI complications, right? And maybe you've heard of Dressler syndrome, but you might not have understood what it is. And whenever you read up on what it is, the definition of Dressler syndrome, it usually start with immunologically, something about immunology, and something about inflammation of the outer layer of the heart, and stuff like that. Okay, clear. We all know that from the name pericarditis, it means the inflammation of the pericardium, the outermost layer of the heart. Sure, understand, clear. But when someone answers or regurgitates the term immunologically driven pericarditis, especially post MI, we need to understand how is it, what is the mechanism, what is the uh, vehicle behind 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 this. Remember, when we have MI, it is an irreversible necrosis of the heart tissue, yeah. And after a while, we cannot replace the heart tissues or anything with new heart tissue. So we can only replace it with connective tissues, and it becomes fibrotic. The place becomes fibrotic. So because of these dead regions of the heart, the body will detect these spots or these areas as something that is foreign, and will try to fight this these so-called antigens. They are not infectious in nature, but it's just because it does not belong to the body. Therefore, the immune system wants to fight against it. Unfortunately, the victim, when the immune system tries to fight, and unfortunately, the victim in this case is your pericardium. That is why your pericardium becomes inflamed. It's not because it's infected, but it's the mechanism is the vehicle behind it is your immune system. That is why the definition of your Dressler syndrome is immunologically and immune. Whenever you read the definition, there's always immunology, something about immunology, and also inflammation of the pericardium. Okay. Now, next would be cancer, of course. If there's any metastasis to the pericardium, um, it can be seen as something that is foreign, and also it can also irritate the pericardium. It can also cause inflammation. Okay, let's see. What do I want to cover next? I want to cover something that is interesting to, oh, very good, yeah. All right. Before we go to putting in diagnosis, we've covered causes already, right? So let's talk about the clinical presentation of patients with pericarditis, and I'll explain why this exists. So patients will normally come in with something in the medical sphere called as positional pleuritic chest pain. Positional pleuritic chest pain. So what does that mean? Positional. It means that very often and not when the patient comes in the emergency department, they won't lie down because lying down will aggravate the pain. They will most often sit. They are in the sitting position, and that elevates the pain. So that's what it means, positional chest pain. So and next is pleuritic. Pleuritic. So understand that this is the outermost layer of the heart. And so as it gets inflamed, it irritates the nerve endings that are around the heart as well, because our heart also has nerve endings. And this causes not just the heart, actually, the chest. And this causes pain as well. Now, another point that I want to talk about about positional pleuritic chest pain is that it also increases during inhalation. The pain also increases during inhalation. Why? Remember when we talked about, what did we talk about? Yeah, when we talk about S3, remember when we talk about murmurs and how the physiology behind S3 and S4. Remember, S4 is always pathological, but S3 can also happen physiologically, right? And the physiological S3 is because of the difference in pressure of the chest when we breathe in, and there is somewhat a push in the heart. Well, I don't want to talk very extensively on it. You can read up on it. You can read up on physiological S3 and revise on it. But the mechanism is also the same. Mechanism is also the same. So it increases during inhalation because of this as well. The same mechanism as your physiological S3. Right? Okay. Next, during physical examination, when we perform pericardial rub, we can hear sounds. We can hear like people stepping on the snow. They call it, yeah, like it sounds like people stepping on the snow. You can go on YouTube and listen to what that means, pericardial friction rub, and what it sounds like. What you do basically is just you take the stethoscope, you just press on the heart, and just let your heart beat on its own. You're pressing the chest, and you're actually just trying to compress the parietal pericardium to your visceral pericardium, and just to push, just to close up that pericardial space or pericardial space sac, and just to see if as the heart beats, and these both layers, they are just rubbing against each other, and if there's something in the sac, you can hear it. So that's what it means, pericardial friction rub. Other signs are pretty non-specific. Your inflammatory signs, which I'm not going to cover, your fever and your tachypnea, tachycardia, and stuff like that. It's pretty simple, straightforward. All right, next is that when we talked about infectious endocarditis, our first step was to establish your major criteria, which means that you will perform echocardiogram, right? You perform your echo. But in pericarditis, instead of performing echo, which you can still perform echo, no problem there. But people usually will start with ECG first. Why? Because on ECG there are specific changes, especially during for acute pericarditis. So what are the changes in ECG? Number one is your ST elevation. You might be wondering, ST elevation, this is MI, right? Your STEMI. True, this is also a criteria for your STEMI. But the thing about STEMI is that you see ST elevation on certain leads, and these certain leads will give you will help you to determine which walls which walls are affected by it, right? But in acute pericarditis, you will see ST elevation in all leads. All, I mean all, from up until 1, 2, 3 AVL, all those things up until V6, all leads. And they call it diffuse ST elevation. That's first point. Second criteria for acute pericarditis is PR depression. PR depression. I'll show you a picture later on. Let's see if I can find it. But anyway, PR depression. Third point is something called electrical alternance. Let's see if I can find a picture. Electrical alternance. Found it. Let me show you. 1 second. ECG for pericarditis first. Let me show you ECG for pericarditis. Okay. Everybody can see, yeah? Okay, you see widespread ST elevation. You see ST elevation in all leads up until V6. Up until V6. You see your isoelectric line, and you see that the ST segment is, all of them are elevated. They look like MI, but it's not MI because MI is very sparse, right? Second is PR depression. Let me zoom closer so you can see the PR segment. Oh, too deep. Let's see if I can see it. Yeah. Here. You see second lead? Here. Your P wave here is below isoelectric line. You see your P wave below isoelectric line. Your isoelectric line is here. So that's your PR depression. Electrical alternance. Electrical alternance, what? See, one is tall, one is short, one is tall, one is short, one is tall, one is short. Yeah, this is why it means electrical alternance. And very often when you see electrical alternance in patients with acute pericarditis, this means this is a serious indication of massive pericardial effusion, to a point that it can also be tamponade. Okay, so we need to end quick. We unfortunately can't cover everything. Let's see. Okay, but no worries, you can still continue next week. Right. 183. Aha, this is a very good picture too. Let me show it to you too. See? This is nicer. Okay. Okay, let's cover a little bit on pericardial effusion and pericardial tamponade, and then we can finish. We'll continue myocarditis next week and rheumatic fever next week. Oh, I thought next week we can cover something else. But anyway, no worry, no rush. So pericardial effusion simply means that there's some form of fluid in the pericardial sac, right? But it's not as much as serious or as emergent as your cardiac tamponade. Cardiac tamponade simply means that it is life-threatening situation where it's a massive pericardial effusion. So it can be anything in your pericardial sac. It can be blood, it can be pus, it can be anything. It can be any form of, it can be even lymph. And you can check for pericardial effusion on echocardiography. Your echo, your ultrasound, you can see some form of fluid in your echo, and that can be any, that can already confirm your diagnosis. So treatment of infective endocarditis, in treatment of pericarditis, acute pericarditis, people normally start with giving NSAIDs. And most of the time it's enough. Giving any NSAIDs, your normal ibuprofen and any NSAIDs, it would be okay. If it is not working, you if it is not working, number one, you have to consider the cause of pericardial effusion. If it's viral, which I mentioned earlier on, is very common, it means that you have to treat the initial problem first. So viral infection, let's say echovirus or Coxsackie virus, you treat that as well. So you have to give your antiviral as well. So you need to treat cause, give NSAIDs, and if it is still not working, if your NSAID is not working, you can consider adding corticosteroids, adding your steroids, prednisolone, when dexamethasone, any steroids that you want to give. However, steroids, it can because of its action, because of its pharmacological action, it can increase risk for reoccurrence. So you have to be careful with that as well. If there is any effusion, you want to drain the effusion, you can also drain the effusion. It's called cardiosynthesis. It's called pericardiocentesis. You can just drain it out and send it to the lab for analysis, and that is enough. Right. Okay. Cardiac tamponade emergency. You have to drain it. No choice. You can't give NSAIDs. You have to drain it immediately. Okay. Actually, there's another point that I would like to talk about, and that is constrictive pericarditis. Constrictive pericarditis. It looks like your restrictive cardiomyopathy, but you know cardiomyopathy that it refers to your myocardium instead of your pericardium. It looks like that, but it is not like that. So we'll just continue next week on constrictive pericarditis, continue on myocarditis, and then we'll cover rheumatic fever. All right. We unfortunately have to end the class because it's 8:30 already, and we stick to time. Do you have any questions before we say bye-bye?
No question.
No question.
Nope. Nope.
All right. I hope that is clear. If you have any questions, just drop in the group. We'll talk about it. Okay?
All right.
If it's just go through the material again, hopefully it sticks on everybody's brain.
Thank
All right.
you.
Goodbye, everyone. Thank you for
Bye.
coming today.
Thank you.
Thank you. Bye.